deal. Show up at regular time if you want to. It's just simply a opportunity to get you out the door a little bit quicker that particular night. And there's a clinical data homework assignment. How'd you guys do that? Okay. What was the arrhythmia on there? It was wasn't there an arrhythmia on that homework assignment?
PVC.
So the premature ventricular contraction. What? How do you know that? Because the QRS complex was
Wide in the garden.
wide and bizarre looking. That's it. I've encouraged all of you to develop a drug list. There's I wouldn't say it's a huge list of drugs, but there's probably a list of drugs is somewhere around 10-inch to 12-inch drugs to know, at least. So make sure that you've got that. And there are a number of key equations to know as well. So one of which is the Fick principle, not Fick's law of diffusion, but the Fick principle. Anyways, there's that. There's Poiseuille's law, which is a really important law because it highlights the importance of blood vessel radius or even airway radius in terms of allowing fluids to flow through them. So those are just some encouragements for you. We're going to do a review session this coming Wednesday night. That's scheduled at 5:30. Just as a show of hands, who's planning on being there for that? Okay, good enough. And then also on Saturday, we'll have a review session as well. Both of those will be taped, video recorded, and certainly the one for Wednesday night, I'll probably post that Thursday morning. It usually takes a couple hours for that to be translated and go through all the stuff that they do out on Zoom. And then the same thing will apply to Saturday's lecture. And the test structure is going to be identical to what it's been for the first three exams. Okay, so that's that. We talked about, we started talking about renal physiology last week, and a couple of critical points I want to make to you is make sure you understand that there are 5 basic functions of the kidney. Those are simply the regulation of concentration of key ions in the plasma of the blood. There is a regulation of blood volume, which is critically important. Make sure you understand that the kidneys regulate cardiac performance. They do that through preload, through EDV, right? And that alters the preload on the heart, which alters the contractility of the heart. Very, very important. There's a regulation pH. Why do we care about the concentration of hydrogen ions? Because it turns out that the concentration of hydrogen ions affects the very structure of the machinery of our cells, the proteins of the cells. There's an endocrine function. A couple of the endocrine functions are the release of erythropoietin to control red blood cell production. And tonight you'll learn about the release of renin. And renin is this very powerful enzyme that regulates or is involved in the regulation of blood volume. And then last but not least is removal of waste products. The basic processes, so let me just back up. Many of these functions up here, these 5 functions, are all related to the functional unit of the kidney, which is the nephron. And the nephron performs these functions through 4 processes: filtration, reabsorption, excretion, and secretion. We're not going to talk about secretion. And last week, you learned about GFR, the glomerular filtration rate. You learned about the 3 forces that determine the GFR, which is PCAP, PVC, and PICAP. Tonight, we're going to get in, so just coming back to our map over here. So you can see now that I modified this algorithm for thinking about cardiac output and what factors determine cardiac output. Under EDV, we've got filling pressure, and of course, underneath filling pressure is blood volume. And now we're wrapping the involvement of the kidney into blood volume. And you can sit there and think about the simple formula, which I laid out for you last week, which says that the excretion rate is equal to the filtration rate minus the reabsorption rate. And then drilling down a little bit further, you should be sitting there saying, oh, okay, what determines GFR? And the answer is PCAT, PVC, PICAT. That's over here on the filtration side of our equation. On the reabsorption side of the equation, we have key factors that are involved in the reabsorption of sodium. And if you heard what I said last week, one of the comments I made is that with regards to the kidney, we're going to keep it very simple and say that the reabsorption of everything is basically linked to the reabsorption of sodium. And in that context, and thinking about that, we've got the renin-angiotensin-aldosterone story, which, as I highlighted for you, is one of the most important stories within renal physiology. So tonight we're going to talk about the reabsorption of sodium. We're going to talk about the reabsorption of glucose. I'm not going to talk about the reabsorption of hydrogen ions. We're going to talk about number 4, which is very important. This is a so-called sodium potassium chloride, and that should read co-transporter after that. So in your notes, please write sodium potassium chloride co-transporter. We're going to talk about the renin-angiotensin-aldosterone system, and we'll talk about the cells within the kidney that act as renal baroreceptors, pressure sensors. Remember, we have baroreceptors that are located in the carotid artery and the aortic arch. We also have baroreceptors located within the kidney themselves. And then once we get done with all that, we're going to get into diuretics. Diuretics are simply a class of drugs that basically increase the excretion rate, or a different way of saying it, increase the rate of urine production. Where's that urine coming from? From your plasma volume. So we can use diuretics to bring down blood volume and in effect reduce the filling pressure, reduce EDV, reduce the preload on the heart, reduce stroke volume, reduce cardiac output, and that's going to reduce the mean arterial pressure. And that's how you need to be thinking about this. All right, so with that, let's get the show on the road. So here's kind of the front end of our description of a nephron. And Mr. Bennett, what is the concentration of sodium here? He's looking at me cross-eyed right now, just so you guys can get a visual of what his face looks like at the moment. That's okay, because I saw Kathy back there raise her hand. She's going, me. I know.
140 milligrams.
Very good. So we're going to just put here concentration of sodium is equal to 140 millimolar. Where's Miss Chan tonight? Oh, I know. Nobody know where she's at. She said, she told me, she goes, I'm not coming to the last lecture because you always pick on me. She said, so pick on Elizabeth instead of me. What's the concentration of sodium there?
140.
Very good. Miss Elizabeth, what's the concentration of sodium here?
14 millimolar.
Peritubular capillary. What's the concentration of sodium there? What's the concentration of sodium here? Why would the concentration there be any different than here? And the answer is, we wouldn't think it would be. Miss Elizabeth, who should I ask next?
You can be back to me.
My hearing's not up. I think she said ask Mr. Corey back there. I shall ask you then. He's shaking his head no. You couldn't see his face, but when I said that, he was like Mr. Ben, his eyes got crossed. Your answer?
You didn't ask the question.
Ah, what's the concentration of sodium here?
140 millimolar.
It is, that's exactly right. Jocelyn, what's the concentration of sodium there?
14 millimolar.
Very good. So remember, our simple mantra is the reabsorption of everything is linked to the reabsorption of sodium. And as it turns out, we've got these tubular epithelial cells that make up the structure of the the proximal tubule. And within their membrane, they have sodium ion channels. And so I'm hoping that all of you would tell me that sodium wants to move from an area of high concentration to an area of low concentration. And so sodium ions are going to move into this tubular epithelial cell. And when they do this, all of you would tell me that the concentration for sodium ions will go up. And of course, the cell can't allow the concentration of sodium ions to go up. And therefore, Ms. Camilla, you're going to tell us, how are we going to get rid of those extra sodium ions that are coming into the cell? Through what type of pump? Would that be a calcium ATPase pump, a proton pump,
A sodium ATPase pump.
sodium, what?
Potassium.
Sodium potassium ATPase pump. So here's our sodium potassium ATPase pump. Oop, shame on me. That don't work. And so we're going to pump sodium ions out of this tubular epithelial cell into the interstitial fluid. And Mr. Vargas, as soon as we pump sodium ions out here into the interstitial fluid, what happens to the concentration of sodium ions here?
It goes up.
It does go up, that's exactly right. So we have an increase in the concentration of sodium ions. And now the concentration of sodium is greater here than it is here. And so sodium ions are going to move, Eric,
back into the circulatory system?
back into the circulatory system via the peritubular capillary. Thumbs up. Miss Maria, as soon as sodium moves from here to here, what happens to the concentration of water here?
Increases.
It does, that's exactly right. And the concentration of water here decreases. And water always wants to be in equilibrium. So what's following right along with the sodium ion?
Water.
Water is following that sodium ion. So sodium ion moves from the lumen of the proximal tubule into the cell. Water moves with it. We pump sodium out into the interstitial space. Water moves with it. Sodium moves from the interstitial space into the peritubular capillary, and water moves with that. And this is an example of what?
Osmosis?
That's right. Excellent. Very good. Now, I hate to keep beating the drum here, but one of your colleagues in here came up to me a long time ago and sat there and said, is the final going to be comprehensive? And my answer to that student was, no, not in the way that you think. But the problem here, it's not a problem. The good thing here is that what we're doing at the end of the course builds upon much of what you learned throughout the course. So in that case, I guess you could say it's comprehensive, but it's not what I would consider to be a comprehensive exam per se. We have these stories, these themes that keep repeating themselves over and over and over again. Continuation of the proximal tubule, so we're still in the proximal tubule. Here's another peritubular, excuse me, here's another tubular epithelial cell. Mr. Cow, what's the concentration of glucose here?
100
100 what?
milligram per deciliter.
Very good, exactly right. So the concentration of glucose is 100 milligrams per 100 milliliters. Okay, I need timeout here. Quick timeout. You guys need to break out a calculator real quick. And what is the normal GFR? Austin, what would you say? What's the normal GFR?
Not sure.
Okay. Mr. Lemmy, what's the normal GFR?
I'm not too sure either.
Okay, all right. Ken?
100 milliliters per minute.
2 thumbs up. Normal GFR is 100 milliliters per minute. I need to know, what is the total volume of fluid that's filtered every day? So you know that the GFR is 100 milliliters per minute. There are 60 minutes in an hour. There are 24 hours in a day. The question I'm asking is, what's the total volume of fluid is filtered every day. It's a big number. Maria, have you got a number?
If I got it right, I think it's 144,000 milliliters, I think.
She says 144,000 milliliters. Let me change that into units, but that's the right number. We could say it's 144 liters. Sit there and think about that. That's a big number. That's not a small volume. That's a huge volume. And as I told you last week, what's quite amazing is that we put all of that back into the circulatory system with the exception of 1.8 liters, because on average, that's what the volume that you urinate every day is, about 1.8 liters. So you're putting back almost 99% of what is filtered. Here's the next step I need you guys to take, and that is, how many grams of glucose are being filtered every day? We'll turn to our biochemist back there for the answer on this one.
What was your question? How many grams of glucose?
Are filtered every day.
Would it also just be 144?
I don't know.
Because if it's 100 milligrams per 100 milliliters, it means to be 1 gram per 1 liter. It's 144 liters filtered a day. It would be 144 grams.
What'd you get?
I'm still doing it.
I like logic 101. Austin, what's your number? Elizabeth, what's your number?
1440.
So we have two individuals who are saying 144 grams. Mr. Corey, what's the molecular weight of glucose?
Oh, wow. I would not know that.
No? You guys calculated it way back when.
180?
180 grams, right? Here's what I want you to ponder. Every day you filter almost 1 mole of glucose. That's 6.02 times 10 to the 23rd molecules of glucose. How many molecules of glucose are showing up in your urine? Mr. Cow?
0.
0. Does that sound like an impressive system to you? It does to me. That you can filter 6.02 times 10 to the 23rd molecules of anything and capture those and put them back in the circulatory system? That's pretty mind-boggling, if you ask me. Well, that's exactly what's happening here every day we have approximately a mole's worth of glucose moving through the proximal tubule. How the heck is it that we're able to reabsorb all these molecules of glucose? Is there anybody out there that can give me a membrane transporter that might help us figure this out? Yes, sir.
Is it like a GLUT1 transporter without those ones? Or is it a glucose calcium exchange without?
Well, let's just back up for a moment. There's two general types of membrane transport. There's diffusion, there's carrier-mediated transport. Under diffusion across the membranes can occur through the lipid portion of the bilayer or through ion channels. If we're talking about carrier-mediated transport, there's 3 types. There's facilitated diffusion, primary active transport, and secondary active transport. An example of facilitated diffusion would be our GLUTs, our glucose transporters. But this is an example of that. This is an example of secondary active transport. And there's a secondary active transporter known as the sodium glucose transporter. Those are the SGLTs, right? You guys learned about GLUTs, the glutes, and there's the SGLT. That's what we have located here in the membrane. So we've got a sodium glucose transporter, SGLT. And this is taking glucose and moving it into the cell. And Mr. Corey, how is it that glucose is moving out of the cell into the interstitial space?
How is it?
Mm-hmm. You just told us a moment ago. There are GLUT transporters. These GLUT transporters are bidirectional. So here's our GLUT transporter. So we transport glucose out into the interstitial space. The concentration of glucose there goes up, and then glucose is taken back up into the circulatory system. Now, just a point of emphasis. Remember, a few moments ago, last Wednesday night, our general operating principle is that the reabsorption of everything is linked to the reabsorption of sodium. And here we have a perfect example of this, is that we have a sodium glucose transporter. Let me put a graph up here. I'm going to create a graph. And on the y-axis, we're going to have glucose rate. And on the x-axis, we're going to have the concentration of glucose. In here, I'm going to go in increments of 0, we'll say 100, 200, 300, and 400. And this is in our standard units of milligrams per 100 ml. Here I'm going to put 100, 200, 300, and 400. And we're going to start out talking about the filtration rate. I'm going to do filtration rate, and let me do that in green. Just to have some context. So we're talking about filtration rate of glucose in milligrams per minute, just to be clear. Eric, what's the normal GFR?
100 milligrams per minute?
100 milliliters per minute, perfect. And if the concentration of glucose is 100 milligrams per 100 mLs, Mr. Corey told us, that means that the filtration rate for glucose will be
100 milligrams per minute?
That's correct. So let's back up. If the concentration of glucose is 0, here, Eric, what is the filtration rate for glucose going to be?
0.
It is going to be 0. That was easy, right? That was the easy one. If the concentration of glucose is 100 milligrams per 100 mLs, then the filtration rate for glucose is going to be 100 milligrams per minute. How do we know that? Because remember, everything is being filtered in exactly the same proportion that exists within the plasma of the blood. If the concentration of glucose in the blood or in the plasma is 200 milligrams per 100 mLs, then the filtration rate will be 200 milligrams per minute. If the concentration of glucose is 300 milligrams, then the filtration rate will be 300 milligrams per minute. And if it's 400, then 400 milligrams per 100 mLs, then the filtration rate will be 400 milligrams per minute. So that's our filtration rate. How about the reabsorption rate? So here I'm going to put in black reabsorption rate, and this is in the same units, milligrams per minute. Mr. Cow, if the concentration of glucose in the blood is 100 milligrams per 100 mLs, what will the filtration rate be?
I'm sorry, ask the question again,
Yep.
please.
If the concentration of glucose in the plasma is 100 milligrams per 100 mLs, what will be the reabsorption rate of glucose?
Most likely 100.
Most likely it would be most likely the right answer. Mr. Cow, if the concentration of glucose in the blood is 200 milligrams per 100 milliliters, what will be the reabsorption rate of glucose?
I'm not sure, but I can surmise that at some point it will max out.
Okay, well, let's have you surmise something different than your surmising, your submission, your surmising.
Yes.
So if the concentration of glucose in the blood is 200 milligrams per 100 mLs, what do you think the reabsorption rate would be?
I think that's another shot for me, so it's gonna be 200.
Yeah, that's right, it'll be 200. This is pretty simple. Ms. Knudsen, if the concentration of glucose in the blood is 250 milligrams per 100 mLs, what do you think the reabsorption rate will be? 250
milliliters or milligrams per milliliter.
250 milligrams per what? How about the reabsorption rate? Talking about rate, we have to have the units of anybody? Time, right? So if the concentration of glucose in the blood is 250 milligrams per minute, the reabsorption rate will be 250 milligrams. Let me back up. If the concentration of glucose is 250 milligrams per 100 mLs, the reabsorption rate will be 250 milligrams per minute. And now we have to return to Mr. Cow. Michael, if the concentration of glucose is 300 milligrams per 100 mLs, what do you think the reabsorption rate is going to be?
300.
You guys heard him. He said 250 milligrams per minute, right? You guys all heard him say that? Brilliant answer. And, Miss Maria, if the concentration of glucose in the blood is 400 milligrams per 100 mLs, you would guess that the reabsorption rate of glucose will be?
150 milligrams per
That's
minute.
correct, it will be. Miss Maria, when we learned about membrane transport and you learned about carrier-mediated transport, I told you that there were 3 fundamental principles of all types of carrier-mediated transport. What were those 3 fundamental principles?
Is it like no red blood cells? No, sorry, I don't know.
Mr. Vargas?
Saturation, specificity. And
Last one starts with a C.
Competition.
Competition, that's right. So what are we seeing here? There's 3 fundamental principles of carrier-mediated transport: specificity, saturation, competition. There's only a certain number of binding sites, and once those become saturated, then we reach our transport maximum. Go back, do yourself a favor, just review your notes on carrier-mediated transport. Hopefully that will just reinforce the principles here. Austin. We're going to do excretion rate. If the concentration of glucose in the blood is 100 milligrams per 100 milliliters, you're going to tell us that the excretion rate is going to be what?
0.
It is going to be 0. That's exactly right. If the concentration of the blood for glucose is 200 milligrams per 100 milliliters, you're going to tell us the excretion rate is going to be 0. Very good. If it's 250 milligrams per 100 mLs, you're going to say? You're going to sit there. It will be 0. If the concentration is 300 milligrams per 100 mLs, you're going to tell us that the excretion rate is going to be correct. And if it's 400 milligrams per 100 mLs, you would say that it's going to be okay. This is really important. Really, really important. Write this in your notes. Is that the reabsorption of glucose only, keyword only, occurs in the proximal tubule. So Andrew, if the reabsorption of glucose only occurs in the proximal tubule, then that tells you where all those sodium glucose transporters are found, right? Are they found in the distal tubule, the collecting duct, the thick ascending loop of Henle? No, they're only found in the proximal tubule. And here's the problem, is that once we exceed a concentration of 250 milligrams per 100 mLs, glucose now spills into the thick descending loop of Henle. And what does it take with it?
Water.
It takes water with it, right? Because now we've got this osmotic effect. And the higher the concentration of glucose, the greater that osmotic effect. Now, for all of you in here, you're regulating your blood glucose at right around about 70 to 100 milligrams. And if you have a meal, it goes up. But your pancreases are functioning normally. They secrete insulin, which brings the blood glucose levels back down. You're not spilling any blood glucose. Excuse me, you're not spilling any glucose into the urine. Ms. Monica, by definition, if you have glucose in your urine, you know that the concentration of glucose in the blood has exceeded what? Oh, interesting medicine right here.
100.
Don't mind me, I just have a bad cough tonight. The question is, if you have glucose in your urine, by definition, you now know that the concentration of glucose in your blood had to have exceeded.
100 milligrams.
This cough is spreading, it's getting worse all the time.
350 or
250, right? Isn't that cool? Medicine right there. By definition, if glucose levels, if glucose is popping up in the urine, you know by definition, at least thinking very simply, that the concentration of glucose in the blood had to be 250 milligrams or higher. Yes, sir.
Is that when you say frequent urination is a symptom of diabetes?
Fantastic. Really good comment. If you didn't hear what he said, is that why they say that frequent urination is a marker of, is suggestive of somebody with diabetes? That's exactly right? Because these individuals who are diabetic have these elevations of blood glucose levels, and we cannot reabsorb all the glucose. We can reabsorb up to 250 milligrams, but you know that once we reach a concentration greater than that, glucose is now getting past the proximal tubule. We've got past all of our sodium glucose transporters, and now there's no way to put glucose back in the blood. And that glucose takes with it, it's got this osmotic effect, it takes water with it. And so, not only is there frequent urination, so write this down because Mr. Bennett hit on an important part of the story, is not only is there frequent urination, especially at night, but there's also something else that accompanies it. If you're urinating a lot, what else do you think a person would sit there and tell you they're experiencing? Say it again?
They're thirsty.
They're thirsty a lot, right? That's exactly right. So 2 hallmarks of this is that frequent urination and they're thirsty. And just on a personal note, my father-in-law, he would have big tumblers like this. You know, we'd be sitting there on the weekend watching a football game, and he's going through those things just left and right. You know, and he had diabetes. But This is part of this. Okay, let's move on. So now we're moving beyond the proximal tubule. And in my diagram that I laid out for you last week, I mentioned that 60% of the reabsorption occurs in the proximal tubule. I also noted for you that about 20% of the reabsorption occurs in the thick ascending loop of femoral. And here, we have a very important membrane protein, and this is the so-called sodium, potassium, chloride cotransporter. This is a major target in treating hypertension. I'll get to that in a few moments. Within the tubular epithelial cells of the distal tubule, there are cells that have sodium ion channels in them. And there are other tubular epithelial cells that also have sodium ion channels in them. But the numbers of these are under the influence of a hormone known as aldosterone. So aldosterone is this hormone that acts on these tubular epithelial cells in the distal tubule, and this regulates the number of sodium ion channels. So, Mr. Bennett, if we come along and we treat the cell with aldosterone, that's going to cause an increase in the number of sodium ion channels, which will do what with respect to the reabsorption of sodium? So if we increase the number of sodium ion channels here, what will happen to the reabsorption of sodium? Reabsorption of sodium will go up, and the reabsorption of water will go up, right? So this system here can be modulated or manipulated through the presence of aldosterone. Okay, now I'm hoping that everybody's got this scheme in your notes. If not, you'll need to get it from your classmates. Now, associated with the afferent arteriole, which is up here in our diagram, there is a special type of cell that's referred to as granular cells. And these granular cells are renal baroreceptors. So they're monitoring the pressure. And these granular cells release a hormone when the pressure in the afferent arteriole drops. And the name of this hormone is renin. So let me write the scheme over here for renin. So we're going to start off this story with a molecule known as angiotensin. This is produced by the liver. And in the presence of renin, angiotensin oops, sorry about that. Let's go back for a second. It's angiotensinogen. So angiotensinogen is circulating throughout the circulation. So here I'm just above the arrow. I'm going to put in parentheses, just so it's clear, we're talking about all this occurring within the blood through the action of renin. That will cause angiotensinogen to be converted into angiotensin 1. So the more renin, the more angiotensin 1. Angiotensin 1 is circulating throughout the body and the blood, and it can be converted into what's called angiotensin 2. And the conversion of angiotensin 1 into angiotensin 2 occurs within the lungs, the blood is being carried to the lungs, and there are cells within the lungs, and they secrete this hormone, or this enzyme known as the angiotensin converting enzyme. And what a great acronym for this. Whoever came up with that, the naming of this did themselves really well. This is known shorthand as ACE. ACE. And angiotensin II will then act on the kidneys and cause the kidneys, the adrenal gland, to release another hormone known as aldosterone. Remember, here, the number of sodium ion channels is under the control of aldosterone. So aldosterone controls the number of sodium ion channels. This is in the tubular epithelial cells. And by controlling the number of sodium ion channels in the distal tubule, we regulate the reabsorption of sodium. And by regulating the reabsorption of sodium, you would also say that we're regulating the reabsorption of water. This then determines our blood volume. Which determines our filling pressure. Which then determines EDV. And ESV through the preload. That determines cardiac output. Well, we'll say that determines stroke volume and cardiac output. And in so doing, that controls mean arterial pressure. So let's say that we have an instance where there's a decrease in the pressure in the afferent arteriole. The granular cells see that and they increase their secretion of renin. So the scenario is there's a decrease in the pressure in the afferent arteriole. The granular cells see that, they increase renin. That means that we're going to convert more of the angiotensinogen into angiotensin 1. And through the action of the angiotensin converting enzyme, we're going to have more angiotensin 2, which then is going to cause an increase in the release of aldosterone. That's going to lead to an increase in the number of sodium ion channels in the tubular epithelial cells of the distal tubule. That results in an increase in the reabsorption of sodium, the increase in the reabsorption of water, increase in blood volume, increase in filling pressure, increase in stroke volume, and all of you would tell me an increase in mean arterial pressure. All right, so now I want to talk about diuretics. And so we're going to start off in that diagram over there to your right, and we're going to talk about so-called ACE inhibitors. So we've got Mrs. Jones, she's hypertensive, she's got high blood pressure, and you decide that you're going to put her on ACE inhibitor. And by the way, ACE inhibitors are an amazing class of drugs. Not only are they effective for hypertension, they're effective for minimizing the remodeling of the heart due to hypertension, so very effective in individuals who are predisposed to heart failure. So we come along and we give Mrs. Jones an ACE inhibitor. Now, here's a couple common types of ACE inhibitors. Diazopril. Very, very commonly prescribed ACE inhibitor. This also goes by another name, which is low tensin. Another one is captopril. And there's a whole host of them out there. But if you see that suffix on the end of these words, the PRIL, the pril, that's a tip-off that you're talking about an ACE inhibitor. So even though you may not have heard of the particular name of the medication, if you see that PRIL, more than likely we're talking about an ACE inhibitor. So sit there and think about this. We've got Mrs. Jones, she's hypertensive. We come along and we inhibit the angiotensin converting enzyme. That means that the amount of angiotensin 2 is going to go down, which means that the release of aldosterone will go down, which means that the number of sodium ion channels over here will go down. That means that the reabsorption of sodium will go down, the reabsorption of water will go down. And so if the reabsorption of sodium and water are going down, then that water is showing up in the form of urine, right? So diuretics, diuresis. Diuresis is an increase in the production of urine. And in this case, we're doing this to try to bring down the blood volume and decrease the mean arterial pressure. Also, I will just say, I'm not going to touch on this part, but these angiotensin converting enzymes, this word angiotensin is in reference to the blood vessels and the tension in the walls of those blood vessels. So if we reduce the tension of the blood vessels, they will dilate, and through Poiseuille's law, you would sit there and say that they dilate, mean arterial pressure will go down. So I'm not testing on that part. I want you to know the angiotensin converting enzyme, its role in the renin-angiotensin-aldosterone story. But I'm just highlighting that angiotensin is having this other effect at the level of the smooth muscle cells of the blood vessels. All right, there's another fantastic class of drugs that come along and inhibit the sodium potassium chloride cotransporter. And here's one of these, furosemide. And there's another type that's very, very commonly prescribed, known as Lasix. So these inhibit the sodium potassium chloride cotransporter, and as a result, we're going to decrease the reabsorption of sodium. And by definition, if we decrease the reabsorption of sodium, we're decreasing the reabsorption of water, which means that we're decreasing blood volume, and now we're just into our algorithm for cardiac output and mean arterial pressure.
What class of medication are you talking?
Thank you for mentioning that. These are called loop diuretics. So we've got ACE inhibitors, we've got loop diuretics. Up here in this region of the proximal tubule, there's another class of diuretics that can be used. And again, a very, very powerful type of diuretic that belongs to a category of diuretics known as thiazides. And underneath here, I'm going to put the initials HCT. And HCT stands for hydrochlorothiazide. A really, really powerful class of drugs. However, yes ma'am.
I could be wrong, but in the clinical field, we use HCTZ because HCT is just inadequate. So if someone's taking it, we abbreviate it as HCTZ.
You're saying it's HC what?
TZ.
TZ?
Yeah.
Yeah, you'll see it HCT.
Oh, okay.
Yeah. But I'm glad you started talking about that, because if you have a patient that's on a thiazide, you need to be looking at what?
Their blood pressure.
Yes, obviously we'd like to look at blood pressure, because that's why we're prescribing the blood pressure, or the diuretic for them. But there's something very important about these drugs, yes.
Sodium levels?
Couldn't quite hear you.
Sodium levels?
She said potassium, right? Brilliant. You gotta be looking at potassium levels, because with these thiazides, you could have changes in the concentration of potassium, and your super instructor for the last semester has been talking nonstop about the importance of potassium, because the concentration of potassium And the extracellular fluid does what? Causes you to go to sleep.
Excitable.
It affects the excitability of cells, right? And what excitable cells are we concerned about in prescribing thiazides?
The pacemaker cells, the neurons.
Yes, that's right. But I'll just say, very, very commonly prescribed, a great drug, a first-line drug for treating individuals with heart failure. ACE inhibitors, HCT, and then you can go with, say, a beta blocker. That's kind of a magic combination for people with heart failure. All right, and one last group is over here. We've got a class of drugs that are referred to as potassium-sparing diuretics. Ms. Monaco, why would we care about potassium-sparing diuretics?
We still need potassium for the whole thing to function.
So we're not going to have any loss of potassium, right? That's kind of the word potassium sparing. We're not going to be spilling potassium out into our urine. Okay, let's see here. Just give me 1 second. I think I've got it. Potassium sparing diuretics. We're going to put amiloride in here. All right. Yeah, let's go for it.
Spirolacto, which category would that be in? Do you recognize that one?
Which one?
Spirolacto?
Don't know it.
No?
Anybody else know it?
It's usually in the treatment of acne.
Okay, yeah, I don't know that one. Okay, you know, for me, the semester has gone by very quickly. As being a student, I know that semesters can drag on. But for me, coming here every night's been a complete blast. I love coming here. Hopefully that shows. We got a lot of talent in this classroom, so I congratulate all of you. The thing that I started off with way back in August that I firmly believe is that for those of you who are going to put your hands on patients, I'm not talking about figuratively, right? I'm talking about conceptually, treating patients. We demand excellence. That's what you have to be shooting for. That doesn't mean that you have to be the Albert Einstein of the medical field. But it does mean that every day you show up to work, you give it your best shot. And in medicine, it's not just knowledge. There's the science in the medical field, but there's the art of medicine as well. And that's how you communicate with your colleagues, how you communicate with patients. So as you guys go forward, always shoot for excellence, both in terms of your understanding of medicine, but also in terms of how you interact with your fellow human being. So with that, I'm done. I'm looking forward to seeing a fantastic